So welcome everyone to the Equitable Injectable PrEP in LA County Initiative. Today we are presenting our first presentation in this workshop series entitled State of the Science, What We Know and What We Still Need to Know About Long-Acting Injectable PrEP. Our featured speaker is Dr. Raphael Landovitz, and I will introduce him after some introductory slides. Next slide. So the initiative was supported by an EHE supplement grant from the National Institute of Mental Health, or NIMH, which was awarded to the UCLA Center for HIV Identification, Prevention, and Treatment Services, otherwise known as CHIPS. And listed below are the team members, myself, Elena Rosenberg Carlson, Omar Nieto, Lara Uskup, and Suri Nzunza. As I mentioned, if you're having technical difficulties, please reach out to Omar Nieto in the chat. Next slide. So this project is a collaboration between CHIPS and the LA County Division of HIV and STD programs. And we're putting this project together in collaboration with support from our community partners and other supporters, Bienestar Human Services, Friends Community Center, In the Meantime Men's Group, and the Los Angeles County Commission on HIV. Next slide. So just a little bit of background about this initiative. So we know that throughout the AIDS epidemic, that Latino and Latina and Black MSM, we have Latino and Latina and Black men who have sex with men and transgender women have continuously lagged behind more privileged and well-resourced white gay male populations in receiving information about the latest innovations in both HIV prevention and treatment. And as a result, Latino, Latina, and Black MSM and transgender women have not been able to benefit from early adoption of these highly effective HIV innovations. This, unfortunately, has contributed to the disparity in HIV that persists today in these populations. Next slide. So the goals of this initiative are the goals of the initiative seeks to address the delay in disseminating information on the latest HIV innovations. In this case, it's long-acting injectable PrEP to our focused populations of Black and Latino, transgender women and men who have sex with men in Los Angeles County. To do this, we are developing and implementing a series of online community workshops to provide accurate and up-to-date information on LAI PrEP-related topics that are of particular relevance to our focused populations and their service providers. So today's agenda, so we will have a presentation by Dr. Landovitz. We will have a question and answer period following his presentation. That's the only time that we will be taking questions. But if you have questions that come up during this presentation, feel free to enter them in the chat. We have reserved some time at close to the end of the presentation or the meeting time to have everyone complete an evaluation of the workshop. This is really important for the project as we seek to identify which groups we are reaching and the utility and importance of the information that is provided in these workshops. As an incentive to get people to stay and complete the evaluation, everyone who completes the evaluation will be redirected to enter a raffle to win one of 3 electronic Visa gift cards for $50. We will have some closing remarks following the evaluation period, describing our future activities. Next slide. So just a few workshop logistics. Participants will be muted during the presentation. If you have questions, as I mentioned, you can enter them in the chat at any time. There is, if needed, you can select show captions icon on your Zoom control panel to enable closed captions. For other technical questions or difficulties, as I mentioned, please contact Omar. And we will be recording this presentation to be uploaded to the CHIPS website for future viewing. Next slide. It is my pleasure to introduce our featured presenter, Dr. Raphael Landovitz. He is a professor of medicine at the UCLA Center for Clinical AIDS Research and Education. He is also chair of HPTN 083 study, which is comparing the efficacy of long-acting injectable PrEP and daily oral PrEP. So welcome, Dr. Landovitz.
Thank you, Ron, and thanks to the entire team for inviting me to speak with you all today. It really is an honor and a privilege to get to share some thoughts about long-acting injectable PrEP with you. I'm going to try to share my screen, and hopefully we will not have technological difficulties. Can everyone see the title slide okay?
Looks
Yes.
good.
Okay, terrific. What I'm going to cover today we're calling what we know and what we don't know about long-acting PrEP. And I'm going to go through some of the science with you all today. And after each mini section, I'm going to tell you what I think is the take-home message about what we know. And then as we get towards the end, I'm going to outline some things that I wonder about. And as we get to the discussion, I'd love to hear what all else you are wondering about and where you think the gaps in the research are and what we need to know to be able to use long-acting PrEP most effectively here in LA County. These are my disclosures. I do serve on a scientific advisory board for Merck. So this is a little bit of a complicated slide. As Dr. Brooks mentioned, I was chair of one of the two trials that led to the FDA approval of long-acting PrEP here in the US. And this is the study design of both the study that I led and our sister study. And our study was called 083, our sister study was called 084. Really, the only thing that was different were the population of people who were enrolled. The 083 study was cisgender men and transgender women who have sex with men. And 084 was cisgender women in the global south. So it was all in Southern and Eastern Africa. You will notice that neither of these studies addressed transgender men. None of them addressed non-binary individuals, and none of them looked at people who inject drugs. And so those are three huge gaps in our knowledge of how to use this product. So I just want to be very clear about that up front. So what this slide is intended to show is what the study design is. I'm not going to spend a lot of time on this, but I did want to make sure we're all on the same page to understand how the study was done, because I'm going to talk about the results, I'm going to talk about the safety, and I'm going to talk about a lot about what we learned in it. So these were people who did not have HIV when they entered the study. And people went through an informed consent process, and then they got randomized to a treatment arm that was either the long-acting injectable cabotegravir or daily oral TDF-FTC, which is the generic name for what many of us call Truvada, and that was daily. And it was a double-blind study. So what that means is that everybody got medications that looked like both the injectable and the daily pill. But in the injectable arm, the injectable stuff, the cabotegravir, was real, and the daily oral pill was a placebo pill. And in the arm where people were assigned to the oral pill, they got the oral pill that was a real functional pill and placebo injections. Nobody got all placebos, and nobody got both active products. But people didn't know which was the active product and which was the placebo product until a time in the study that I'll tell you about in a minute. And more importantly, their providers didn't know which they were receiving either, so they could objectively evaluate for any side effects and be objective in reporting the findings. So the way the study was designed, people initially got the cabotegravir, which is the injectable product, as a pill form for 5 weeks. And during that period, they also got the TDF FTC pill for 5 weeks. And the reason for that is because you have a long-acting injectable product, that once you give it as a shot, you can't take it away and it lasts in the body a really long time. You want to make sure someone tolerates it before you give them the long-acting version of that chemical. So there was a 5-week oral lead-in period, and then a 3-year period where people had this direct oral injectable comparison. And then after the 3-year period, or if they stopped the injections earlier, they went into what's on the right side of the slide, which we call step 3, which is basically just the proven, standard of care at the time, daily oral TDF FTC for a year. After that, to let the cabotegravir, if they had gotten it, wash out of the body while still maintaining biomedical prevention. So both studies, 083 and 084, were designed in this way, and I hope that makes sense to you. So the study was going along. It started enrolling in 2016, December of 2016, and it was going along, enrolling. It was almost fully enrolled. And then COVID hit in early 2020, as everybody remembers. And we had a scheduled review board meeting. It's called a DSMB, Data Safety Review, Data Safety Monitoring Board, that in May of 2020 had been pre-planned to look at the data. And this group of people who had nothing to do with the study team at the NIH looked at the data, knowing which people were assigned to which arm. And using a pre-specified set of rules, they looked at the data in May of 2020, and they said, stop the blinded study because the cabotegravir was significantly better at preventing new HIV infections than the daily oral TDF FTC. Stop that part of the study and offer everybody that information, and offer everybody the choice of which product they want to continue with this new understanding that the cabotegravir worked better. I will spare you a little bit of the details, but the HPTN 084 study in cis women really had a similar life story just about 6 months later. So they were a little bit later in starting by about 6 months than we were. And in November of 2020, they had exactly the same result. That same monitoring board looked at the results and said, same is true in cis women in Southern and Eastern Africa. Stop the study, stop the blinded study, and offer people that choice. So with that, I want to tell you about how well the drug worked, what we call efficacy. And this is a little bit of a complicated study design, but if you look at the left side of this slide, what you can see in sort of the orange bars is in the people who got cabotegravir, there were just 14 new infections. That's an HIV incidence rate of 0.44 per 100 person years. And in the TDF FTC arm, there were 41 new infections, and that's an incidence rate of 1.29. And on the right side of the slide, what you'll see is when you compare those incidence rates, you can see that the cabotegravir incidence rate is 66% lower than the TDF FTC arm. And if the statistics told us that that met a statistical definition of superiority. And that's a statistical definition, and we'll come back to what I think that means for clinical practice a little bit later, because just because something is superior statistically doesn't mean that slam dunk everybody should be on it. And I think that's a big misconception, and I'm going to talk more about that in just a minute. So I hope that makes sense. That's what we found in the 083 study. I will tell you that it took us about a year to amend the protocol and get enough cabotegravir medication in each of the countries where the study was being done. It was being done in 7 countries at 43 sites. So people actually were unblinded, so they knew which product they had gotten, but still on their original randomized study treatment for about a year after that May 2020 DSMB meeting. And these were the results after an additional year of follow-up. And on the left side of the slide, you can see that the numbers have gone up slightly in both arms. But what I really want you to focus on is on the right, the ratio of how much better cabotegravir did compared to TDF FTC was identical. It was 66% lower HIV incidence in the cabotegravir arm compared to the TDF FTC arm, even though that additional year of follow-up was no longer blinded. So people knew what they were taking. They knew which was their active product. There were no more placebos involved. So people were just getting shots or just taking pills. And that benefit was identically preserved. And I was a little bit surprised, to be honest. Often when you have a blinded study, people are sort of not adherent to one or the other of the interventions because they are taking bets on which is active. But at least the way it sort of seems, the ratio in which people took and benefited from these products was the same in the open label portion. I was a little surprised at that, but it does give you reassurance that that finding is a true finding, that about 2/3 reduction in HIV incidence is the right comparison in this population. I do want to now show you the results for the cis women study. This is a very similar slide that shows you the same kinds of information, but to me, as impressive as the 083 study results were, this is a mind-blowing, staggering, super exciting, head-exploding kind of result. When I heard this, I almost cried. I think the background for why I thought it was so impressive is I think everyone knows that using TDF FTC, we've really struggled to see the same level of benefit for vaginal exposures that we've had for rectal exposures with oral PrEP. And we've all scratched our head about why that is and what we can do to improve the effectiveness of oral PrEP. But it's been really hard to get these population level benefits from oral PrEP for vaginal exposures, particularly for cis women, particularly in Africa. And here you have a result where it was essentially 88% better for the injectable product compared to the oral TDF FTC product. There were only 4 new infections in this blinded period in the cabotegravir arm compared to 36 infections in the TDF FTC arm. And you can see on the right, and just in case people are wondering where I'm getting this percentage reduction is, hopefully you can see my cursor moving around a little bit. It's a little arrow here. So you see this, this 0.12 number here, right? So I take 1.0, and I subtract out that 0.12, and that's 0.88, and that's 88%. That's where I'm getting that percentage reduction from. So this is a ratio, and I hope that makes sense how I'm getting those numbers. And so that you can believe me that that's what these slides are showing. So the same thing happened with 084, that, you know, people were unblinded and then on their randomized regimen for another year before we could implement that choice. And this slide now is updated to that additional 1 year of blinded experience, including it. So there were now 6 infections that were new in the cabotegravir treated participants compared to 56 in the TDF FTC arm. And if you look over on the right, now it's 0.11. Now remember, you take 1 and you subtract out that 0.11. So now it's 89% better. So, you know, essentially the same number. It's 1% different, but honestly, these measures aren't super that precise. So to me, it's again, a completely preserved ratio benefit, just in a different population. And, you know, I think we have this conception that oral PrEP works better for rectal exposures than it does for vaginal exposures. And that may or may not be true, and we can talk about that in discussion period. But here, what it seems like is there's a better comparative effect for vaginal exposures than there is for rectal exposures. They're both great, and both products work really well, but the relative benefit is actually better for vaginal exposure. So it's a little bit of the flip of what we talk about with the oral PrEP. So that was really an exciting result. So for me, this is the bottom line for the efficacy piece of this, right? So long-acting cabotegravir is very effective at preventing HIV in cis men and trans women who have sex with men and cisgender women. And these are the numbers. 66% reduction in HIV infection that are new in cis men and trans women, and 89% reduction compared in cisgender women. I really want to emphasize both products, the TDF-FTC and the cabotegravir, were highly effective, but the cabotegravir did better in both these populations. And we can talk about why I think that is when we get to the discussion point. Then a lot of people say to me, okay, I see that, but what about in specific populations? What about people like me? What about people like my friends? What about different parts of the world? So people ask me specifically, what about young people? What about trans women compared to cis men in the 083 study? What about in the US, the Black or African-American participants, which was 50% of the US enrollment, I want to point out, compared to the non-Black participants? What about region globally? And the long story short, and you can see based on the little plot that's on the right side, is the cabotegravir was better in all of these different groups, no matter how you break down the analysis. In some of the cases, because there were smaller numbers, it didn't reach statistical significance, but the study was not powered to actually have statistical significance in all subpopulations. So I'm not bothered by that. For me, the take-home message is the direction and really the magnitude of the effect is consistent, whether you look at young people, and this study defined as under 30 or over 30, the trans women in the study versus the cis men, the US Black population compared to the non-Black population, and by region. So it was preserved. And then when you look in the 084 study, the same thing was true. They used a cutoff for younger populations of 25, but they saw maintenance of their effect in direction and essentially in magnitude in that population, and dependent on what kind of hormonal contraception people were using, which is a really important finding because there's some suggestion of differences in HIV risk based on type of contraception. And then based on body mass index, because there's a very wide distribution of body mass indices in the African populations that were studied. And there was some suggestion, as I'll show you in a minute, that the drug may last longer in people with higher body mass indices. So that was something that that study looked at really carefully. So I hope that's reassuring to people, because to me, the take-home message from these two slides that I just showed you is cabotegravir. It's also very effective with really preserved effect size in young people, in Black individuals, in trans women, in people from various regions of the world. Didn't matter what kind of contraception people of childbearing potential were using, and individuals with higher body mass index. So that's my take home. And again, hopefully if you've got questions this raises in your mind, you'll put in the chat and we can address that at the end. People always say to me, was it safe? Were there side effects? What were the side effects that people talked about? So the number one side effect that was reported, and really the only one of significance, to be honest, were injection site reactions. That means pain, swelling, tenderness at the site where people got the injection. Throughout both of these studies, the only place people were allowed to get the injection was in the gluteal muscle. That's the part of the buttocks. That's sort of the upper outer quadrant of the buttocks. It could be either side, but it did have to be a buttocks injection. We can talk more about what we know about alternative injection sites. I think I have one slide about that towards the end, But as of right now, the only place that this injectable PrEP regimen is authorized to be given is in that buttock muscle. And what you can see here is this is the 083 data, is overall, and I'll orient you on the left side of the slide to the left of this sort of black dotted line here. You can see the percentage of people who reported any injection site reaction in the cabotegravir arm was basically 80%. So 8/10, 4/5 of people had some injection site reaction at some time. But interestingly, even in the people who were getting the placebo injections, there was about 30% of people who said they had an injection site reaction. So even with sort of a fake injection, it's not fake, they're actually getting an injection, it's an inert substance, it didn't have cabotegravir in it. Just getting a shot in your butt caused about a third of people to have some pain or discomfort there. What I want you to notice in the color coding, though, is green is mild, yellow is moderate, and red was severe. Okay, so the amount of red on this slide is really low. Most of it was mild to moderate. And if you look on the right side of this dotted line, you can see that the injection site reactions, it really went down over time. So people either said, you know what, I don't like this, and you're not giving me any more of this, or they sort of decided that it wasn't that bad. And as they stuck with it, the rate of people reporting this pain and discomfort went down. What I will tell you is about 2% of people in this study had these sort of red reactions here. They're small amounts, but they did happen, where it was severe enough that people said, you know what, I don't like this and I don't want this anymore. So this isn't 100% for everyone. Remember, this is the cis men and trans women study. And now I'm going to show you the result. Oh, first I'm going to tell you a little bit more about the type of reaction, then I'll show you the cis women's data. So what kind of reactions were they? How long did it last? So this is all, you can see that the average length of time that it lasted was 3 days. And it seems like it pretty much started about a day after the injection for most people. So this red sort of diamond tells you the average time from injection to the onset of the pain. So you can see that about 60% of people who had a reaction had pain, about 24%, almost a quarter, had just tenderness. And this 15% was other. Some people it got red, some people it caused a little bit of a nodule under the skin, but you can see that it resolved after an average of 5 days for these other reactions, and all the other ones resolved by 3 days. So these were short-lived when they did happen. So I hope that makes sense to people. These are the cis women's data. And you'll see it's not color-coded the same way. I don't have the granular data about the grading of how severe the reactions were. I'm told it was mostly mild to moderate also, but you can see the rates are much lower than they were in the men's trial. You know, in over here, we had about, 60%, and this was down about 20%. So when I talk to the leaders of the 084 study, what they tell me is, well, obviously women just tolerate pain much better than men, and that's the bottom line. That maybe that's a part of it. I know I'm sort of squeamish about pain, but I'm also told that in a lot of parts of the world, people have the idea that injectable medications are the best medication. And in a lot of parts of Africa and South America, that is sort of the sociocultural context, is that perception is the best medications are injections. So there's also, plus a lot of injectable contraceptive use, much more familiarity and affinity for injections than necessarily we have in the US. So that may be contributing to it also. But what I want to really point you to here is the bottom bullet on this box over on the right. Is in the 084 study, none of the women, even those who had these injection site reactions, decided that the injection site reaction was severe enough for them to stop it. And I think that's really important to notice. One other thing I wanted to mention, because we talk about this a lot when we talk about any medication that's used to treat or prevent HIV, is weight changes. This is a very hot button topic in the HIV treatment community right now. It's a big hot button topic in the PrEP community right now, is which drugs do or don't have differentiated effects on weight gain. And I got some bad news for all of you. We're all gaining weight, about 1 kilogram per year. So that means that's really terrifying to me. Since I started working on the HPTN 083 study, that means I've probably gained 8 kilograms, which explains a lot about what the scale tells me. But regardless, I wanted to show you this comparison of weight changes in 083. And I'm going to ask you first to look at what's at the very top here. So at the top, here's the bottom line. Over 2 years of follow-up, it looks like the cabotegravir arm people, they gained about 1.2 kilograms per year. And the TDF-FTC people only gained about 1/3 of a kilogram per year. But that's actually a little bit misleading, because if you actually look at this, what's below here, what's really clear that's happening is, first look over on the right. In the second year, these were virtually identical. Everybody gained 1.1 kilograms per year. But over on the left side, here's what's really driving this. In the first year, the cabotegravir people gained a little bit of weight, sort of what was almost constant across the whole study. But the TDF-FTC people lost weight in that first year. After the first year, everybody was gaining weight at about the same rate. But just in that first year, cabotegravir people were already gaining weight at sort of what you could argue might be a baseline weight gain. But the TDF-FTC people lost 0.5 kilogram of weight. And a lot of people have been discussing why that is. Is it a direct drug effect, or is it sort of this nausea, gastrointestinal side effect that we've heard described when people start TDF-FTC PrEP? And no, this is not resolved in the scientific literature. Nobody fully knows the answer to this, but obviously this is something that people are really interested in and really factors into decision making that people have about which drug they prefer or which one they would like to be on. So I just wanted to point that out as a safety issue. And then the other thing I wanted to bring up is bone safety. And we hear a lot about TDF-FTC being associated with loss of bone mineral density. And the concern that that raises is whether or not that's going to ultimately, if people are on it for a long time, lead to fractures. And that's not been seen. I want to be really clear about that. What we know about TDF-FTC PrEP is, yes, it does make your bone mineral density go down when you use these very sensitive bone density scans called DEXA, DXA. But what's really interesting about TDF-FTC is if you stop taking it, within 6 months, your bone mineral density gets back on track to where it was before you ever took TDF-FTC. So that's something that I think isn't often discussed and sort of gets minimized, but I want to make that point. So with the cabotegravir comparison, we only looked for 2 years. So this is really new data. We just presented this at the CROI conference last week. So this is hot off the press. You're among the first people not at the conference to see these data. But cabotegravir made people's DEXA readings go up, and the TDF-FTC made the DEXA readings go down. And your first impression might be that cabotegravir was good for bones and TDF-FTC was bad for bones. But remember, this is really short follow-up. I can't tell you what happens after 2 years. There wasn't a difference in fracture rates, and we really need more information to know what's going to happen longer term and what happens if you stop the cabotegravir. You know, if it looks like it's going up, does it then go back down when you stop it? We don't know. So it's way premature to say that cabotegravir is healthy for your bones. By these early measures, it looks like if somebody has like osteoporosis or a history of osteo or weak bones to start with, and you're afraid to use TDF for that reason, that cabotegravir is probably an okay alternative and isn't going to add to that problem. That's my interpretation of that. So a little bit of a busy slide, I apologize. But for me, again, this is the bottom line for the safety that I just showed you, all of those slides. Cabotegravir was safe and well tolerated. The most common side effect we saw were these injection site reactions. We have this sexy name for it, ISR. I apologize, everything's abbreviations, you know that. The majority of those were mild to moderate, and they decreased with time. So either people said, I'm out, I'm done, or they sort of acclimated to them, or it just gets better with time. And very few of these injection site reactions actually were bad enough to cause people to stop taking it. In terms of weight, like I said, I'm sorry, simple truth, we're all gaining weight. People on CAB and TDF were all about the same rate, except in the first year, where the TDF FTC people lost weight, and that accounted for that overall difference over 2 years. And then by these very sensitive bone density measurements, the DEXA scans, it looked like the numbers were better for CAB-L8 compared to the TDF FTC. That's only over 2 years. No clinical differences. What I mean by that is there wasn't an increased rate of fractures in one arm over the other, but you wouldn't really expect to see those changes with just 2 years. We really need more data. So I hope that makes sense about why that's my take home from this and what we still need to know about that. A lot of people ask me about pregnant women. Like, suppose a person is of childbearing potential and they need HIV prevention. Is CAB safe for the baby? And the long story short is we don't know for sure yet, but the 084 study, if people got pregnant, or as the leader of that study is this wonderful team of women. One is Sinead Delaney Moret-Lewey from Johannesburg in South Africa. The other is Mina Hosseinipour from a site in Malawi. They're the leaders of that study. What they tell me is in 084, if a woman fell pregnant, that's the official term. Here in the US, we would say they became pregnant, but they say fell pregnant. So I'll use their word. They had to stop getting cabotegravir. They went on TDF FTC at that point, but they had clearly been exposed to cabotegravir when they first became pregnant. And this is what we know with that information, is that there are 63 pregnancies in the CAB arm. You can see my cursor here, and 23 of them are still ongoing. There were 31 live births. And there were a couple of pregnancy losses, most early on in pregnancy, and there were no birth defects. And when you compare that to the people who were in the TDF FTC arm, you can see that the numbers really aren't different. There may have been a little bit more numerically early pregnancy losses, but that was not statistically significant. And there actually were fewer mid-pregnancy losses. So, so what's really good is they're ongoingly collecting data. And now in the stage of the study that 084 is in, they're actually allowing women who become pregnant to continue cabotegravir dosing because of this early safety data. So we will get an enormous amount of additional data. And they're also doing a breastfeeding subset on that population to understand if cabotegravir gets into breast milk and how much the infants are exposed. So we are going to get a lot more data on that. Everyone acknowledges that that is critical to understand as we look to implementation, and we just don't have the full data set yet. So again, this is my bottom line in pregnancy. Data are still being collected on the safety of cabotegravir during pregnancy and breastfeeding, but to date, with limited data, it does not suggest that there's a safety concern. And that's really important. And I bring that up because some of you who've been following this field, there's a cousin drug of cabotegravir called dolutegravir that in 2014, there was a suggestion that it might contribute to birth defects of a severe nature. That has now been basically proven wrong. It doesn't seem to be associated with birth defects, but it raised this whole concern about this whole family of drugs of, was it safe in pregnancy, and should we not be using it in pregnant women? It caused a lot of concern and changes and discussion during the conduct of the 084 study that had to be resolved with an enormous amount of stakeholder input about what people wanted, what people needed. So that's what we know to date. We will be getting more information from the 084 study, so please stay tuned about that. So pharmacokinetics. So that's, I don't know, it's not even Big Word Wednesday, and I feel bad for putting that up on a Monday. It's Monday, right? Yeah, okay. But what that means is drug levels. Okay, so what do we know about drug levels and what they do with cabotegravir? And I know this looks like a lot of spaghetti, but this is actually from the phase 2 study. So not 083 or 084, it's actually from an earlier study that I also led. It was called 077, because again, we're so good at sexy names, you know, with these studies, right? So this is from 077. These are the people who were born male. So cis men and trans women. And the reason it's broken out by that is there's something about sex at birth that governs the way our bodies metabolize this drug. It's not fully understood yet, but that's how it sorts out. So I apologize that that's a somewhat awkward distinction, but that's sort of how it works out. And what you can see just from looking at these plots is there's an enormous range of how fast these lines go down. Right? I mean, just looking at that, you can see they all start from somewhere that's pretty high on the left side of the screen, and then they kind of go down at different rates. And right, and some of them, it's pretty flat, right? It's kind of seems like it's taken forever for it to go away. And the bottom line is, this is our current understanding of how this drug works. In some people, it washes out really quickly. In some people, it seems to last a really, really, really long time. The average length of time it takes for someone who's born male after their last injection for it to completely wash out of the system is about 43 weeks. Okay, that's the average. But what you can see here, if you look at the axis on the bottom of the screen, is there's a wide variety. And, you know, if you sort of imagine those lines that look pretty flat, how far they go out, you know, some of them look like they could go out to like a year and a half or more on that. And the bottom line is the only things that we know that contribute to this variability is this sex at birth and body mass index, which is this formula that we put height and weight into. It's a combination of your height and weight. And people with higher BMIs, the drug seems to last longer in the system. And you might say, well, obviously that means it's somehow hiding out in fat cells, but that's not immediately clear. So we don't fully understand everything that's contributing into this variability. I want to be very transparent about that. Now, these are individuals born female. And what you'll notice here, and I'm just going to flip back for a second compared to the males, the curves look like they sort of are all a little bit flatter, right? It looks like they're all sort of headed more out to the right. So the average time for somebody going to undetectable who's born female is about 62 weeks. And if you sort of squint your eyes and you look at some of those flatter curves that go out further, some of them actually go out to about 2.5 years. And again, same thing. We don't know what is leading to all this variability except for this sex at birth and body mass index. And there's an incredible amount of variability. So there's still an enormous amount to learn about this. Why does this matter? Well, I'm going to ask you to stick with me just for a second. I'm going to show you a couple of slides that I need you to sort of understand how they're designed. And then I want to show you a couple of examples. Okay. These are a schematic of the plots that I'm about to show you. Okay. On the x-axis here on the bottom, which I'll show you where my cursor is, right? This thing down here, this is the weeks after people went into the study. So this is basically time, right? On the y-axis here, this is the level of cabotegravir that is in people's blood. Okay. these dotted lines that I've marked here, these are various stages of levels of cabotegravir in the blood that are meaningful in the animal studies that were done before we studied cabotegravir in humans. So really what you want to see is people not going between these lower than this sort of second line here. That's what you really don't want to see, okay? And what you're going to see here are these orange circles, and those are people's actual measured cabotegravir levels in their blood over time. These green lines are going to be when somebody got a shot of cabotegravir, okay? And the blue and the red lines are various time points at when someone broke through cab prep and their testing turned positive. The blue line is what happened at the sites, and the red line is what happened when we looked back retrospectively on stored samples and did ultra-sensitive testing on it. And I'll come back to that in a minute. Okay, everybody with me? Say yes. Okay. All right, here's what you expect. Okay, this is a real participant in HPTN 083. What you see here with the orange dots is they got oral cabotegravir. That's why they're not connected with lines at first. But when they took the oral cabotegravir and you measured it, they had high concentrations, high levels of cabotegravir. And then they started getting shots, and, you know, they got shots and they had concentrations and everything was good until they disappeared and stopped taking cabotegravir. And then they were exposed to and unfortunately became somebody with HIV. So the bottom line is don't stop your PrEP if you're still at risk. But what you see here are what we like to see with the levels, good high levels. And I'm going to show you one example of somebody who had unexpected levels. And I wonder if it contributed to cab prep not working for them. So remember, I showed you those people who had the really more rapid washout of the cabotegravir from their body. So this person took the oral lead-in and they had good levels, and then they got their injection and it washed out really quickly. They got another injection and it washed out really quickly again. Another injection washed out really quickly. So this person, it washed out super quickly on multiple occasions. And ultimately, they became somebody with HIV. And whether or not these low concentrations between injections contributed or not, I don't know, but it makes me concerned. Now, I want to really remind everybody, this is one case out of 2,500 people who were exposed to cabotegravir. I don't know how often this occurs in people who didn't get HIV in the cabotegravir arm, but it clearly indicates to me that there's a lot more we need to understand about cabotegravir to give people the full confidence that we know that there isn't a small chance that this could be them and this could be a breakthrough mechanism. I hope that makes sense, but I can't say enough. We've seen one case of this, one. But I wanted to show you how those other spaghetti-like charts that I showed you could play out in real life, because this is a real person. And this is a real person's plots. So what's my take home about pharmacokinetics? For people born male, the median time from the last injection to the time when cabotegravir washes out is about 10 months. For people born female, it's about a year and 3 months. Okay, people with higher BMIs, it lasts longer in your system. And for some reason, some people have this really fast washout. And some people have said to me, do you think it's a genetic thing? What do you think's going on here? And people who are really smart experts in pharmacokinetics tell me that they don't think that there's something genetic going on here. They think there's something about the injection depot. So something about that muscle depot that gets where the injection gets placed, that it washes out of that depot faster in these people. We don't know if it's something about the muscle, the amount of muscle, the amount of fat around the muscle, the fat content of the muscle, or something else entirely. We don't know. But based on the pattern of what people see, people much smarter than me tell me that that's what they think is going on. Clearly, we need more information. What about the PrEP failures? I showed you one example there. What do we know about PrEP failures? People like to really dig deep on this. So I'm going to ask you to bear with me as we talk about this. I want to remind everyone, though, as we talk about this, both medications worked really, really well. So we're going to talk about some rare cases where this didn't work and try and get a little bit of understanding into why it didn't work in the cases where it didn't work. Okay? Want to be really clear about that. So when we were looking at this, we gave each clinical situation where there were PrEP breakthroughs a letter name. And you can see what the letter names are here and how they're defined. I'm going to go through each one and tell you what we learned from each case. Okay? So let's start at the very beginning, because that's a very good place to start. Those of you who know me hopefully are giggling, because that's a Broadway musical reference, and that's what I live for. So group A, these are people who, despite our best efforts, actually had HIV when they went into the study. So they hadn't even gotten a dose of PrEP medication yet. We screened as best as we could. We missed it. They already had evidence of HIV when we went back and looked carefully on stored samples before they ever came in the study. What did we learn from those people? Ooh, animation. Okay. If we don't find people who actually have HIV before you start PrEP agents, and that's called the acute or the eclipse phase of the infection. It means very early infection. Cabotegravir, long-acting, can make it really challenging to find later. So the tests get all mucked up once you administer the cabotegravir. So you really have to make sure someone doesn't have HIV before you give cabotegravir. If you fail, and by you, I mean a provider, fails to diagnose HIV infection, what it can lead to is you can miss that and keep giving people cabotegravir because you think that the tests are negative, and you would be wrong. And that's really important because it can lead to resistance. Okay, we'll come back to that in a second. There are two groups of cases. We called them B and BR. These are people who became people with HIV at least 6 months after their last cabotegravir exposure. So they really were off cabotegravir when they were exposed to and acquired HIV. What we learned from these cases is something that we knew from oral PrEP. If you don't take it, it doesn't work as a PrEP agent. Really important. I mean, you think that that's pretty obvious, but people are always surprised when I say that in my clinical practice. We have 3 participants who actually were exposed during that period of washout. We call that the tail. And a lot of us, as we were thinking about this, worried that if somebody got HIV during the tail, it would lead to resistance to cabotegravir and other drugs like it and make that HIV harder to treat. Turns out it doesn't seem like that happens. If you get HIV at least 6 months after your last cabotegravir injection, you don't get resistance. It also doesn't protect you, but you don't get resistance. And I think that was a surprise to many people. It's reassuring. It doesn't mean it can never happen. We're still looking, but in the data we have, no resistance. Also, if somebody's been off cab for a long time, and then they decide they want to start cab again, it's really important, just like with those A cases I mentioned, that you make sure someone is still, it does not have HIV before you give any more CAB, because again, that's going to make it harder to diagnose again if they really have HIV and you don't pick it up before you re-administer or restart the cabotegravir, and that can lead to resistance for sure. What's also really important is in this study and in clinical practice, we have been very careful to say, hey, if you stop your injections early or you come off the injectable cabotegravir, here's a year of the TDF FTC to what we call cover the tail, right? That means provide ongoing HIV prevention while you're in this washout period. In 083, when we did that, when we gave people the TDF FTC and we looked in their blood measurements, there was no evidence that they actually took the oral TDF FTC, which is a really sobering reminder to me that people who don't like or can't effectively routinely use oral pills, asking them to use oral pills is not going to be successful. So some of you may be saying, well, obviously, why would you think any different? But at the same time, we were trying to give people the next best option for PrEP when they stopped the injectable. But it's a reminder that we need choice. We need options because there are going to be interventions that don't work for people, and we need alternatives to switch them onto. And if people aren't good at taking pills, asking them as their option to take pills, not going to be successful. So again, you may be saying, well, obviously, but you know, scientists are slow on the uptake, so we're slow to learn. Okay, C cases. Now this is gonna harken back to this same thing that I just said. People who don't do well taking pills don't do well taking pills. So we had 3 cases during the oral lead-in of PrEP breakthrough. So again, if you don't take oral CAB, it doesn't work. Same as with oral TDF FTC. We don't know yet how forgiving the pills are to missed doses. And likely the protection isn't instantaneous when you take your first pill. Everything has an onset of protection. We don't know how long that delay after you start taking the pills is. And that's something that gives people a lot of concern, and rightly so. But the pills can also muck up your HIV testing and make it harder to detect that infection. And that can lead to actually somebody going on to getting the shots, which can further make things complicated diagnosing that infection. So to me, and I want to be very clear about this, this is my opinion, the FDA in the US made the oral lead-in before you start injections optional. To me, if people are not good at taking pills, asking them to take pills for a month is not a smart idea. Now, you may have someone who's scared of a side effect, is scared of getting a shot because it's long acting, and will want to do that. And I think in that case, it may be a reasonable thing to do, but they have to understand that if they don't take the oral cabotegravir pills during that period, they are going to be at risk still for getting HIV. And sometimes that's a disconnect in people's mind. They think, well, I can take a couple of doses here and there and figure out if I tolerate it. But what you may not get with that is the HIV prevention activity that people want during that period. So in my mind, unless somebody really, really is enthusiastic about it and thinks they can stick to it, I don't recommend the oral lead-in. As I mentioned, like with the A cases, if people break through CAB with high concentrations with the oral, it can lead to integrase resistance. And then finally, let me tell you about these cases. And these are the ones that I get asked about the most. So people who CAB didn't work for them and they took all of their shots perfectly on time. And then DX are people that they were mostly on time, but there was at least one delay of at least 10 weeks. These are shots administered every 8 weeks when they're supposed to. Okay, remember, these are rare cases, but this is what we learned. So as with the others, the injections delay figuring out that there was a breakthrough. That's 100% clear. The cabotegravir concentrations in the blood of these D cases were as we expected them to be. There were no surprises. So it wasn't unexpectedly low concentrations of CAB that explain these failures. And when you break through, it's like a smoldering fire. And what I mean by that is it's really a low-level infection until it leads to integrase resistance, and then it breaks through and sort of becomes, for lack of a better word, like a volcano sort of erupting, okay? So it smolders, and then it erupts after you get resistance. So that is a dangerous situation when it does fail. It's rare, but in my mind, not a situation you want to be in. It's interesting because with this smoldering infection, you actually can find it earlier if you use extremely sensitive diagnostic tests like a viral load test. You can also find it often before you get that resistance that comes with that volcanic eruption that I talked about. Unfortunately, it's a very expensive test that isn't available in a lot of parts of the world. Here in the US, it is part of the FDA and CDC recommendations for use of cabotegravir PrEP, but in a lot of parts of the world, it isn't available or isn't feasible, which to me is a huge call to action for advocacy that we need better, cheaper point of care diagnostics to be able to find these infections earlier to prevent the resistance. That's my call to action. Okay, so this is the resistance summary for cabotegravir in my mind. And I broke it out based on the clinical scenario. So I hope this is useful to people. So in the top, right, if you start cabotegravir PrEP and there really was HIV infection there and you just didn't find it, will you get integrase resistance? Yes. If you're using the oral lead-in, that's OLI, and it breaks through, 2/3 of them, yes, you'll get resistance. If you are taking your injections on time and it breaks through, rare, very rare, only 6 cases documented out of 2,560 some odd people, will you get resistance? Yes. But was there resistance if people broke through because they were late? No. Was there resistance if it happened during the tail? No. Interesting. We would never have guessed this when we started this study. So I hope this slide is useful for summarizing what we know so far about resistance with cabotegravir breakthrough cases, because this is the total of what we know as of today. What about these testing delays that I've been talking about? What does that mean? So this is a little bit of a funky slide. So it's from the CDC. And what I want people to know here is this is what happens to the blood tests as somebody is acquiring HIV infection. So this lighter blue line here, right, the first thing that happens is what's called the RNA, which is the nucleic acids from HIV, they go up, right? So you can catch that on a viral load test. And then usually between 2 and 3 weeks after, the antibody titer goes up. And that's what we measure in most conventional standard HIV test results, okay? The RNA, the viral load stays up, it peaks often very high and then comes down a little bit. But then basically when you go above this line, this is where your HIV test, your conventional HIV test is measurable. Your test turns positive. So first the RNA, then the antibody test. I hope that makes sense to people. That's normally what happens, okay? What we believe is happening with cabotegravir is this, because cabotegravir is an anti-HIV medication that doesn't wash out of your body. This is what happens. With the blue line, right, instead of the RNA sort of going up and being detectable, it kind of wavers right at this level of detection and it goes up and down. So here, when it pops up, you can catch it, but then maybe it goes back into hiding again. And so it's really difficult to find. And the antibody level is delayed in coming up, and then it goes back down again. It disappears. and then it can come back up again. So you can get what I call flickering of these HIV test results. And it's really difficult to figure out, is it just a false positive result? Or is this the beginning of a CAB PrEP breakthrough? And this is the challenge with long-acting PrEP. I don't think this is going to be unique for cabotegravir. I think it's probably going to be something we're going to have to struggle with all long-acting PrEP agents. And what it means to me is we need a lot more advocacy for more research for better diagnostics, because what we have right now, not good enough. So the benefit of long-acting PrEP, it works really well. You don't have to do something every day. The problem with long-acting PrEP is it makes the rare cases when it does break through much more difficult to find. I hope that makes sense as to the why. So again, these are my take-home messages in the testing delay. So RNA or viral load testing finds infections earlier, but it costs a lot, may not be feasible in many settings, and it may confuse people because you don't know, is it a false positive or is it real? We are studying this in the ongoing 083 and 084 studies. We're in a phase called OLE, which stands for Open Label Extension. We're studying this. I hope to have more information for you soon, but right now I don't know the answer to what's the best approach. Again, once you're in the tail 6 months after the last injection in 083, there is no confusion. There is no delay using viral load compared to normal antibody-based testing. But that is for cis men and trans women only. Remember, I showed you that individuals born female, those red curves, they were a lot more spread out. I don't think it's going to be just 6 months after last injection for individuals born female. I'm betting it's going to be longer. We just don't know yet. So the data is just not mature enough. We will have those data. I just don't know today what to tell you. Okay. So I'm going to try and finish up here so we can have time for conversation and discussion. But what did we learn about the clinical use and implementation? And we're going to come back to something I said at the beginning, that providers still need to make smart decisions with patients for what they want to do, even though there are a lot of questions that we don't know the answers to. So I call this making good decisions absent good data. And the first question is, what do you start? And to me, people say to me, which drug is better? The answer is whichever is going to be easiest for the patient, the client, the consumer to stick with. That's the best PrEP. Long story, very short. And just because cabotegravir in these 2 studies was statistically superior, if somebody hates injections or they're going to disappear and not get their injections on time, injections aren't going to be good for them. So there is no ethical or moral obligation to move every PrEP patient to CAB. I want to be really clear about that. What is the time of onset to protection? We really don't know.
So we can do the thing where we, all the pharmacy, see who has it installed.
So I think somebody's not muted. Now we're muted again. Okay, thanks. We don't know the answer to how fast you get protection. People ask me this all the time. Here's what I tell them. I don't know, but with the pills, you should have levels that are protective within about 4 hours of taking that first pill. That's the CAB pills, okay? With the injections, it's somewhere between 2 and 7 days. I don't know any more granularly than that. Half the people should have protective levels by 2 days after that first injection. 95% of people will have protective levels by a week after. That's as much as I know today. How long can you be delayed and have it still work? Again, I don't know, but for the 083 population, so cis men and trans women, I wouldn't go more than 9 or 10 weeks. For cis women, it seems like, and there was some data presented at CROI last week that helps support this a little bit, you may be okay out to about 12 weeks. We don't know for sure yet, but there's a suggestion that that is likely okay. I wouldn't do that routinely. I wouldn't give everybody cabotegravir born female every 12 weeks. But if people are late, I don't think you have to panic out to 12 weeks. So when it doesn't work. So I think what I've told you makes it pretty clear. It's poorly understood to date. And how do you, I hate this word. I hate it. How do you salvage that situation? What does it mean? How do you treat people who have CAB PrEP breakthroughs? And, you know, I have some thoughts on that. I would not use an integrase inhibitor-based regimen, at least not if it was within a year of them being on cabotegravir. That's my spidey sense, but we really don't know the answer yet. And then here's the million-dollar question. Do we have the global, social, and political will to figure out how to use it? And I say that because here in the US, the insurance landscape is so complicated, it's become virtually impossible to use. And do we have a commitment to make sure that we are going to get this to the communities who need it the most, that are not benefiting from currently available HIV prevention strategies, including oral PrEP? And I think that what I would like to leave you all with, and I do have 3 or 4 more slides, but I'm not going to show them here. You will distribute them and people can see them because I want to leave time for conversation of at least 15 minutes, is this is my call to action to all of you. We need to advocate as strongly as we possibly can to figure out how to remove all of these barriers, the pricing barriers, the clinic-related barriers, all the operational barriers that right now are making it virtually impossible to use injectable PrEP in the United States. And we're going to need to expand that activism globally as we get regulatory approvals in other countries, because I fear that the pricing is going to make it impossible for programs to be able to afford. And it would be the biggest tragedy in the world if these really incredible study results were not able to be translated into population level benefits because of price or the lack of political or social will. I'll stop there and I'll thank you for your attention. Happy to answer any questions or engage in more discussion.
Great. Thank you, Rafi, for a very exciting and interesting presentation. We will start to take some questions. We're going to start with those that were in the chat. We do have to say that at least 5 minutes for evaluation, so we have about 10 minutes for Q&A, but we can work with you to finish up answering any questions that we don't get to today. So Elena, do you want to start?
Yeah, absolutely. We have a lot of amazing questions in the chat. So I'm just going to start with one question that had quite a bit of interest from participants. Luciano asks, how soon after injection of Apretude does it reach rectal tissue for receptive anal sex as well as vaginal sex?
Yeah, so great question. We think that the timing of PK peaks parallels what we see in the plasma. There are fairly limited data to this at this point. There's single injection data only from the rectal and vaginal compartment. So what I want to caution people about is the same way I am estimating or guessing the time to protection based on plasma levels, that's also sort of looking at what happens in rectal and vaginal tissue as well. The peaks are about the same timeline. So 2 to 7 days after your first injection and about 4 hours after the first pill. But what makes it really hard to be sure about those numbers at this time is we don't actually know what the protective levels are. And the reason we don't know that is there have been so few infections, it's very difficult to do statistical analyses and figure out where those breakpoints are. So I know that's very unsatisfying and frustrating, but it's a good, bad problem to have.
Thank you. Another question is, if a patient can't get their scheduled injection within the window to receive, is oral cabotegravir an option until they can receive their injection?
Great question. The package insert from the US FDA says that if you are going to be a week or more late for your injection, you should bridge with an oral product. And they say if it's going to be 2 months or less of bridging, you can use oral cabotegravir. And if it's longer than 2 months, you should use another approved oral product. To me, that makes absolutely no sense. And if you look at the IAS USA guidelines, which, full disclosure, I had a hand in writing, we make it a lot simpler. Don't take oral cabotegravir as a bridge. Take either TDF FTC or TAF FTC as a bridging product. The main reason for that is you can't just walk into a pharmacy and get oral cabotegravir. It can only be ordered from one central pharmacy, and it has to arrive by mail order, and it's very difficult to get, and it's really complicated, and it's never going to be FDA approved for PrEP as an oral product. So unless there's some allergic reason that you can't take a short course of a tenofovir-based oral PrEP product, that would be my recommendation.
Thank you. Do the hazard ratios still favor cabotegravir when you remove the HIV infections that occurred during the lead-in phase and those who did not get dispensation on time?
Yeah, so we did an analysis. It's called OBSP, which is on-blinded study product, which is when you take away the people who were late or missed or gone and all of those things. And yes, it's a preserved hazard ratio.
How is depression being monitored in being on injectable PrEP? This person's had a few patients express a change in mood since starting Apretude.
Yeah, so it's a great question. So we used standard depression measures on a computer-assisted self-interview to evaluate that. And we did have a high background rate of depression in the studies, but we did not see a difference in depression rates or worsening of depression between study arms in this study. I do think it's important for us to look at now that it's getting more use, because that is something that has been associated with other integrase inhibitors. So I would not be surprised if there were a signal there, and I think we need to be vigilant. Remember that these studies only encompass about 5,000 people total between the two studies exposed to cabotegravir. So now that it's going to be in use, we're going to see orders of magnitude higher numbers of people on the medication, and we may see side effects that we didn't see in the studies because of the low numbers.
We've gotten a couple of questions about medication washout. One is, what was the BMI or other, specific findings noticed of the persons who washed out quickly between injections?
Yeah, so the one case that I showed where it was sort of that very sawtooth pattern, their BMI was like 28. So it wasn't super low, it wasn't super high. It was sort of actually right at the median for the study population. So I don't have a good reason why that particular sawtooth pattern had happened. We looked very carefully at other medications they were taking, at any STIs, any recreational substances, and we could not find anything that accounted for it, at least that we measured. So it's frustrating that I can't give you more of an explanation for it.
Thanks. Another question is, if it's known that there's a gap with non-binary individuals and trans men, why were they excluded from the study? And are there any studies currently to look at transmasculine folks on testosterone and efficacy?
Great question. So the reason they weren't included in 083 is the phase 2 data for individuals born male were ready before the data for individuals born female. So that's why 083 was cis men and trans women. 084 obviously came along once the data for individuals born female were enrolled, were available. Why the decision was made to not include transmasculine populations in that study, I cannot speak to. I wasn't part of that study. But we certainly acknowledge that it's a huge gap that needs to be investigated, particularly interactions with gender-affirming hormone therapy, which we did look at in 083. And my co-chair for the study, Dr. Beatrice Grinstein, presented those data at the AIDS 2022 conference last summer. If people are interested, I can orient you to that presentation. But it's a huge gap. And I want to be clear, non-binary people were not specifically excluded, but as we all know, if you do not have language and instruments and representation from non-binary communities, you can't expect representation in your study populations. So clearly we have a lot of work to do better in that regard with our prevention studies going forward.
So Elena, it looks like we're out of time and we need to move to the evaluation, but I'm sure you have tons of questions in the chat, which we will get to after this workshop, and we will send them to all the participants. But now we really do need to move to our evaluation, which is an important part of the project for us to learn who's attending, what are you gaining from this project? Do you want more of these kinds of workshops? So Elena, are you sharing the evaluation link?
Yeah, I'll share it in the chat now. And I think Omar is going to pull up some slides.
Yes. Ron, do you still want music playing?
Sure, it'll be a couple minutes. So Elena is putting a link in the chat to our evaluation form. It's completely anonymous, the evaluation piece. Once you submit your evaluation, you will be redirected to submit another form with your name and email address that will enter you into our raffle to win one of 3 $50 electronic Visa gift cards.
Ron, let me turn this
down.
Let me turn this music down so you can continue speaking. Okay, I'm going to share my screen again.
So did everyone get the link?
And if not, I can also post it in chat.
Yeah. So as I mentioned, once you complete the evaluation, you will be redirected to another form to enter the raffle. And that's just your name and email address. We will only notify the winners of the raffle, and we will do that on Friday, this coming Friday, March 3rd.
Yes.
So please stay online. As you complete your evaluation, we do have some closing remarks to describe our future activities that we'd like to share with you guys. So just take a couple minutes to do the evaluation and enjoy this instrumental R&B music. I will add that Dr. Landovitz did say, if I remember correctly, did say that we will be able to share the slides after the presentation. So we will create a PDF form and share those slides with anyone that's interested. We are also recording this workshop so that it will be available on the CHIPS website for future viewing by anyone that's interested.
Yeah. And all this information will be included in a follow-up email when we're done with our workshop.
Anyone having problems linking to the evaluation survey, let Omar know, or Elena.
Ron, it looks like we have a couple minutes. Do you want me to move on to the closing remarks slide?
Yes, people can continue to complete the evaluation as you listen to the closing remarks. So first of all, we want to thank you all for attending this very first workshop from our Equitable Injectable PrEP in LA County initiative. We will be offering several other workshops over the next 18 months as part of this initiative. And here are some tentative topics for our future workshops, which we've sort of developed in collaboration with our community partner, DHSP, and other partners. In the meantime, Bienestad and Friends Community Center. So just some upcoming topics. Next will be our policies and programs that facilitate access to LA PrEP here in LA County. Conversations with Latino, Latina, and Black MSM and transgender women community leaders about the use of LAI PrEP within their communities. And then third is considerations for clinical implementation of LAI PrEP here in LA County, looking at more the implementation process, actually using LAI PrEP within clinical settings. And your suggestions as part of the evaluation, you can suggest topics that you think would be important for us to cover over the next 18 months. And I think that's about it. So I'm hoping people complete the evaluation before you leave. We really appreciate it. It's very important to us. But go ahead and take us to the closing slide. So once again, thank you for more information about the Equitable Injectable PrEP in LA County initiative, or to be included on our listserv for future workshops. Please contact Elena Rosenberg Carlson, who is our facilitator for these workshops. And here's her very long, unfortunately, email, but hopefully it's in the email. It'll be in the email, the follow-up emails that we send to everyone with additional information.
And thank you again to Dr. Landovitz for your extremely informative presentation. We're seeing some thank yous in the chat for that. So we hope to see you all at our next session. Thank you.